Welcome everyone to this webinar this evening that we're hosting. Whether you are following here on Zoom or following through our Facebook page or for the event. So the theme today of the webinar will be Ending TB and the Current Challenges for a World Free from Tuberculosis. As many of you may know, TB is in the last years, the greatest infectious killer in the world. And we are not quite catching up with the goals set by global leaders to try and end TB. And this great challenge has also become harder in the last year with a lot of awareness and resources being focused on COVID. So we thought it would be important to take an evening to focus on TB. If I can change the slide. Oh. Yeah, okay. So who are hosting this are the Swedish Society of Medicine's Junior Doctor and Student section. My name is Sixten. I'm a student from Lund and also Public Health Secretary for the organization. With me hosting, I have Hanna. Can you introduce yourself?
Yes, thank you, Sixten. So my name is Hanna Jandal, and I'm based in Umeå. I'm the Secretary of Ethics for this organization this year, and I've been working with infectious diseases for about 2 years as a junior doctor, and also done some research in TB. So very happy to be here with you all today. And then we also have Emma with us. Would you like to introduce yourself?
Hello, everyone. My name is Emma Stenbacka, and I'm also a board member of the same association. I'm very excited to participate in this webinar, and I'm very excited to hear what you all got to say. I will be in charge of the questions from the audience, and we will answer them in the panel discussion. So write them and I will keep track of them. Thank you.
Yeah. And you can write your questions in the questions and answer function, which I think is at the bottom of your screen. So just quickly about the organization. It's an organization for Swedish student and junior doctors of medicine, working for the personal and professional development of our group of this group in terms of important subjects such as global health, public health, and science, which I guess are, and many more, but some of those are quite relevant for this event today. Yes, Anna, will you continue?
Yes, because with us here today, we have 3 excellent speakers, and I would like you to introduce yourselves, and we'll start with Olena. Could you please introduce yourself and tell us how you started to work with TB?
Hello, thanks a lot for inviting. My name is Olena, and I work as a researcher at Umeå University. Originally, I'm from Ukraine, and when I did my PhD at Umeå University, I was thinking that I should build back connection with my country in Ukraine, my home university in Odessa, and this is how I started thinking about tuberculosis, and then trying to apply the skills and knowledge I acquired in Sweden to do something with infectious diseases in Ukraine, and tuberculosis is one of the most important, in my opinion.
Thank you so much. And then we have Rashmi. Would you please introduce yourself? I think you are still muted, Rashmi. We can't hear you.
Yeah.
Perfect. Yeah. Thanks.
Sure. Yeah, I'm Rashmi Rodriguez, Associate Professor of Community Medicine at St. John's Medical College, Bangalore, India. Well, I have been working with TB now for the past 5 to 6 years. I first worked with HIV infection and then used my experience with HIV and treatment adherence to improve treatment treatment adherence with tuberculosis, which is one of the challenges that we have, especially in a country like India. So I have kind of worked with developing mobile phone support systems for tuberculosis adherence, and I'm working with several other vaccine trials and other things in India with respect to tuberculosis. Yeah.
Thank you, and we're very happy to have you here. Also, thinking of the different time zones. I know it's pretty late now for you in India, so thank you for taking the time joining us. Sure. Then we also have Per with us. Welcome. Would you please introduce yourself?
Thank you very much. Yeah, my name is Per. I'm professor of infection medicine at Lund University. I live and work in Malmö in southern Sweden. I'm also an infectious disease physician since a long time. My main interests, both with regard to my clinical work and research, is HIV and TB, especially HIV-TB co-infection. I started to have an interest in TB long time ago, actually, even before I started medical school. And it's quite, I'm glad to meet Rashmi, because my first work on TB was actually in Bangalore at St. John's Medical College in the beginning of the 90s. I did a master project there on TB adherence, or rather loss to follow up of TB patients in Bangalore. So I'm very glad to meet you here in this. Yeah. And currently I'm mostly working on TB projects that are based in Ethiopia, or on TB and the TB HIV infection and TB pregnancy, for instance.
Thank you. Yeah, you're all very, very welcome. And also very nice to create this platform for us all to connect today. Please, Sixten.
Yeah, I also see that we have Casper here who has been helping out planning this seminar. I didn't know you would quite make it, but Casper is also here listening in, I can see. I'm just gonna show the agenda for today so that we all know the plan. So we're trying to keep the time until 7 p.m. And after this presentation that we've finished, we're gonna start off with some presentations from our panelists. Just to get us quickly introduced to the subject, with Per starting out with an introduction to tuberculosis, Olena following up with more about global and local challenges, and then Rashmi will dive deeper into the TB perspectives of India, which is the country in the world with the highest burden of TB. Then we'll take a small break, and we have actually a quiz for you all that we hope you will like, and then we will end up with our panel discussion towards the end. So with that said, I guess I'm going to give the word over to Per to start out with his introductory presentation.
So thank you very much. I got rather a long list from Sixten of topics that I could introduce into this, like the basics of TB, and that would have taken considerably longer than just 1.5 hours. So I'll keep it very simple. I know that you are all medical students and doctors, so you know a bit about TB, but just to set the stage and reintroduce you this topic. And tuberculosis is one of the most common infections today, but it's also one of the oldest infections that we know in mankind, which has been discovered in fossils and mummies from as far back as 70,000 years ago. And the origin is actually the same as the origin of mankind, that is the Horn of Africa, where the first isolates of TB have been detected. TB is caused by a mycobacteria, which is called Mycobacterium tuberculosis. I won't go into too much about the bacteriology here, but that's the cause of the disease. And interestingly, with regard to this history of TB, it has adapted to its host, the human immune the human and our immune system over these thousands of years. And people also speculate that maybe our immune system has in fact adapted to cope with tuberculosis, because as we will come back to, most people who are exposed to or infected with Mycobacterium tuberculosis, they never develop disease. So tuberculosis is an airborne infection. It's spread through an aerosol, which originates from a person with pulmonary tuberculosis, which is expelled when coughing, but also can expel from other, like sneezing or singing, for example. And this aerosol can remain in the air for a couple of hours. So people who are in that environment can get exposed to TB if they breathe the same air. So this is a brief figure about the natural history of TB infection. So what happens if a person inhales this aerosol, which is contains Mycobacterium tuberculosis? There are actually some parts of this that we don't fully understand yet, but it seems that many people who inhale Mycobacterium tuberculosis, they actually clear it before they establish infection through innate immune responses in the mucosa. But some people develop an infection, which also can be cleared by the adaptive immune response, especially T cell responses. But already at this early stage of infection, in some people, the immune system fails to control the bacteria, and they can develop TB, what we call primary TB, which can happen early after you acquire the infection, maybe not that early as 4 to 6 weeks, but at least during the first years, 1 or 2 years after infection. In other people who get infected with TB, the immune system manages to control bacterial replication, but what we consider today is at least that they fail to eradicate this bacteria, and that is the source of, that can be a source of reactivated disease later on. That's what we call latent tuberculosis. And we understand that as a small number of viable mycobacteria that exist in granulomas in the lungs. And in absolutely most people, these nothing happens with these granulomas. Most people don't develop disease ever. And this is actually a big question mark, I think, because maybe a proportion of these people actually may eliminate this bacteria over time, maybe over 10 years or something like that, but we have no methods to determine that. But in some people, this latent tuberculosis can become reactivated later during life, what we call post-primary tuberculosis. So why is it that some people develop active TB, whereas most people who are exposed or are infected with Mycobacterium tuberculosis never get sick? And this is an important concept for tuberculosis, is the balance between the bacteria and the host immune response, which also explains why many conditions in humans can facilitate the development of active tuberculosis. That is conditions that affect the capacity of the immune response directed towards TB. And we know now that the strongest risk factor for developing active TB, if you have latent TB infection, is HIV. If you have untreated HIV infection, the risk of developing active TB is 10 to 15% per year, as compared to 10% over the lifetime in people who are HIV negative. HIV infection is fairly new, but there are a lot of other conditions that are known to facilitate development of active TB, like malnutrition, young age, old age, also immunosuppressive therapies of different kind that have also been introduced during the recent decades have been shown to increase this. And then there are also factors that are not related to diseases of the host, but rather bacterial factors like smoking, which is estimated to double the risk of active TB, as well as alcohol and drug use. So this is a figure that can show how this balance can be tilted from latent tuberculosis with a few contained dormant bacilli, and if the host response is weak and the bacteria can take over and active TB can occur. So we've known TB for a long time, and we've also learned a lot about TB since not just during the last decades, but this was an important disease in the 19th and 20th century. And I think some of the earliest medical research actually, and quite good research that we still rely on, was on tuberculosis. So we have a curative treatment that can cure people from this disease and reduce mortality. Along with that, treatment of active TB also leads to interrupted contagiousness and interrupts transmission. So it has double effects. And currently, treatment of active TB is actually considered to be one of the most cost-effective health interventions that we know of in medicine. So why haven't we succeeded? Well, there are several challenges on the control of TB that we will come back to in this webinar. I think first of all is that TB can infect anyone, but it's not evenly distributed in most societies, and people who belong to population groups that are vulnerable are those groups where TB is most common. And many of these people also have factors, like I explained before, that make them more prone to develop active TB if they are infected. And they may also have lower access to healthcare, which creates this vicious spiral situation where they can also infect other people of the same group. HIV co-infection is a major problem that has emerged over the recent decades. Other problems are the lack of good diagnostic tests that we can use to find active TB, as well as latent TB if you really host viable bacilli. And even if we have treatment, we have not used it wisely. That has led to increasing rates of antibiotic resistance. And it's considered that not only is TB the leading infectious cause of death, but also the leading cause of death of a microorganism which has drug resistance. And we have a vaccine which is very old and not effective, so we really need more effective vaccines for prevention of tuberculosis. And we'll touch a little bit on these topics, like how do we diagnose TB? Well, to diagnose active TB, we need to find the bacteria. If that's pulmonary TB, it will be in sputum. But if it's in another organ, we need to take samples from the affected tissues. And sputum microscopy, which is often the only method available, has rather low sensitivity. So sometimes in real life, in high burden setting, we have to diagnose TB from other criteria which have low sensitivity and specificity, which means that some TB can often be missed. What about treatment? I won't go into the details of that, but we have globally principles for treatment that's called DOTS, which has 5 components. What we commonly think about when we talk about DOTS is the principle of directly observed therapy, where the patient should come to a health provider and get the drugs and swallow the drugs observed so that we can ensure a good adherence. And we use combination treatments that include the antibiotic rifampicin, which allows us to shorten the treatment to commonly 6 months. That's for sensitive TB, but we have a big problem with resistance, as I mentioned, which is called multi-drug resistant tuberculosis. And there are many of these TB strains are also resistant to a lot of other antibiotics that can be used to treat tuberculosis. Sometimes we almost have no drugs available. This has been most common in Central Asia, but it's now spread globally. And the reason for multi-drug resistant tuberculosis, which is interesting to to discuss is that it's actually a consequence of poor programs for TB. And that both the diagnosis and treatment of multi-drug resistant TB is complicated with poor results in most situations. This touches a bit on Olena's topics that we consider today, that we have about 10 million new cases of TB every year, 1.4 million deaths, and they are not evenly distributed in the world. More than 80% of cases of active TB are in 30 high burden countries. The highest incidence is nowadays in sub-Saharan Africa. And that hasn't always been the case. So this is an example of how HIV, another viral infection, has fueled the incidence of TB in Southern Africa. You can see here how the rates, notification rates for tuberculosis in several countries have exploded after the spread of HIV. And this is just to show the disproportionate burden of HIV TB co-infection in sub-Saharan Africa, where, as you probably know, 2/3 of people living with HIV live where TB infection is also common. And Olena will come back to TB in Europe. I'll just mention a bit that in Sweden and in Scandinavia and all of Europe, tuberculosis was extremely common. Not that long time ago, in the beginning of last century, it was really the major disease in Sweden, but this is just to show that even before we got antibiotics, even before we got effective other treatments, the rates of TB decreased, and that's a consequence of improved living standards. So the epidemiology that we see in Europe right now is very different, and we see, for example, in Sweden that 95% of our cases are in immigrants from high incidence countries. But we still do have some spread of TB in our own population. Just to exemplify the spread of a special TB strain in Denmark, which has also affected us in southern Sweden. And that strain is not originating from immigrants. It's not spread in immigrants. It's spread in homeless people living in urban areas who often have many other psychosocial and socioeconomic problems. So I will finish with that, just a very brief introduction, and I think Olena will continue to fill in.
Yes, thank you very much, Per, for that introduction.
Should we continue directly, or we first ask questions to Per? How was it?
You can continue directly, and I think we'll take all the questions at the end.
Okay, we'll do that. Could you see it?
Yes, it's perfect.
Okay, great. So I will try to do full screen. No. Sorry.
No worries. We can say that if you have questions already now, you can start writing them in the Q&A, and you find that on the bottom of the screen on the panel, and then we'll collect the questions while we have the other presentations.
Yeah, okay. But guys, I will continue like this. I hope I can do, oops. I can just move a little bit like this, make it smaller, and this one is bigger. Is it okay like this? Do you see the slides?
Yes, we do.
Right.
It works.
Okay, so I will continue. Thanks, Per, for a very nice introduction. I will just mention who I am. I am a microbiologist. I'm not a doctor, molecular biologist, a researcher, and I work at Umeå University. My implication is tuberculosis. Currently, I'm a part in the international project that deals with tuberculosis. This is the map where our project is located, and I'm located in Sweden, in Umeå. So we're focusing on diagnostic of tuberculosis. And also I'm a vice chair of TBNet, which is a network for clinicians and the researchers. It's a very nice network, and we're especially interested in young people joining the fight against tuberculosis. So I hope some of you probably would like to join us and work on research in clinical tuberculosis together. So I will continue. And as Per mentioned, these 10 million people being ill with tuberculosis every year, and almost 1.5 million die of tuberculosis. So this is a great emergency. As Sixten mentioned, it's the biggest killer among infectious diseases. And only COVID nowadays managed to kill more people than tuberculosis so far. But with tuberculosis, it happened from year to year. It didn't appear now. Again, as Per mentioned, it's a very old disease. And we've been living for it. And every year, these millions of people were dying and being sick. So this is a question that even United Nations worries about. And fighting tuberculosis is a part of Sustainable Development Goals. As you probably know, United Nations has its Sustainable Development Goals, something that leads our globe, the whole world, to the better life for all people. And the General Assembly of United Nations in 2015 set up one of these goals, good health and well-being. And this has in it one of the topics to end the epidemics of tuberculosis and also other major diseases like AIDS, malaria, and some other diseases. And the goal is to do this by the year 2030. And that's not so long time left, right? Now we're living in 2001. So how are we fighting tuberculosis on this high level? There's also anti-TB strategy that is good to know what it is about. It's also produced by important organizations like WHO in 2014. They put a goal to put the end to the tuberculosis epidemics. The targets are very ambitious. So by 2035, comparing 2015, we need to reduce tuberculosis death by 95%, cut the new cases by 90%, and also have zero catastrophic cost to the families affected by tuberculosis. Because the catastrophic costs is very much real. Of course, in Sweden, probably only several vulnerable groups are affected by tuberculosis. But globally, it's communities and countries are suffering from this, and families really suffering catastrophic costs. These are just very normal, ordinary people. And we want to stop that through these tools that developed by United Nations and WHO or programs. There's also a part of these goals. There's a high-level meeting that was in 2018 where the leaders of the countries gathered in New York, and even the health ministers, and they've been discussing how to do more targets to reach on the step to elimination of tuberculosis. And also it has been decided, for example, here I marked with the red dots, that 30 million people should be provided by the preventive treatment for tuberculosis. As Per mentioned, we have this issue with tuberculosis that there is a latent form. You are not really sick, but you have it inside, the bacteria residing inside of the body. And when you're exposed to some adverse conditions, it can happen that the latent tuberculosis break out into active. For this, you should take preventive treatment. If you're a risk group, for example, a person living with HIV, then you need to take the preventive treatment, or a child. And so the goal was to treat 30 million people and also increase funding for research and also everyday fight. Let's see how we're doing with the targets. How we are meeting these targets, because we have really ambitious plan and everything is like really cool. So are we meeting them? If you look at these very nice posters prepared by WHO to the World TB Day, we can see here the incidence. The target for 2020 was a reduction by 20% if you can see probably here. And now we have 9% reduction. So we're not meeting this target exactly. Then we have TB deaths. This is globally. And the target was the reduction of 35% by this year that passed. And now we have 14. And then we have also the catastrophic cost to the families, which are not met either as it was supposed to. Then we have our preventive treatment, 30 million people that should be treated. And totally it's been met by 21%. Of these quite good targets, achievements on the people living with HIV. Because like really, if you live with HIV, you have to do take care of your tuberculosis control, because it's very easy that people living with HIV become sick with tuberculosis if they're exposed. And here, luckily, we have very good preventive treatment for those group of people. Also, for households contact to the people who had active tuberculosis, if they're children. Well, not fantastic, but still 20%. But for other household contacts that we were planning and hoping to have preventive treatment, we're really not getting anywhere. So the conclusion is, my friends, is that we are missing targets quite a lot. And if we look at this curve of decline, the theoretical decline, this is a little bit old article assessing the situation in 2018, but see the current global trend in the decline of tuberculosis and the one that we need to have to achieve, then we would understand that we're not achieving the goals. So tuberculosis will be with us for a longer time. One of the main reasons is that we don't have vaccine so far. And here we come to one person, a friend of mine, Timur Abdullayev. We're not friends, but we know each other quite well. Timur is the activist from the TB people and the activist and fighting for the rights of people affected by tuberculosis. And this is his recent picture I borrowed from his Facebook post where he's saying, I'm thinking how we're reaching the targets when with the COVID 1 year and it's $2,000.8 trillion invested. And the target for tuberculosis was set for 13 billion per year for universal access and TB prevention, diagnostic and treatment care, and just 2 billion for the research and development because there is no vaccine, you know. The BCG protects children from the tuberculosis meningitis, but it's not protecting people from contracting developing active disease. There's 20 vaccines in the pipeline for tuberculosis, but it's still not even close to being implemented. For COVID, everything happened within 1 year with these massive investments. And of course, COVID is a major emergency, but still, ladies and gentlemen, let's compare these activities invested in COVID and also what we have been dealing with in tuberculosis. And people like Timur, they're really, really annoyed by this. So here, what I want to touch a little bit on multi-drug resistant tuberculosis. This is a global map from the Global TB Report. And you see that some countries are more affected by drug-resistant tuberculosis. This is very much in Europe because these are countries in Eastern Europe. And you see that on very close to the borders of the European Union, there are countries that have multi-drug resistant tuberculosis on a very prevalent and common level. So what is special with Mycobacterium tuberculosis is that it develops mutations for drug resistance directly in its genome. Many bacteria species, as many of you know, have plasmids that they can pass from one to another. And this is how they develop the resistance to antibiotics. But also if you stop using these antibiotics, bacteria can clear the plasmids, get rid of them because it's like a burden, and then it will disappear. But tuberculosis develops the mutations in the genome. And so they will be there forever. That also open for one interesting method of studies, which is genome sequencing. So genome sequencing is used now in Mycobacterium tuberculosis, both for research and for surveillance. And here I have an example of one study where I'm a part, and that one from Ukraine. So if you see here, this is a phylogenetic tree of the strains that we tested from Ukraine. And this is like two regions that we sampled in Ukraine. One of them, the region where I'm born, is Odessa region. And through the genomic sequencing, we found 3 outbreaks in these 2 regions of Ukraine. And if you look at the map, there's, especially in this part, the drug-resistant pattern of those bacteria is marked. And many of them, the outbreak strains, they have multi-drug resistant, pre-XDR resistant, and XDR resistant. This is the very difficult resistances. If you want to treat it, the treatments long, and this is very aggressive treatment with at least 4 antibiotics for 2 years. That's a hard treatment. And in 2015, when these samples were collected, in Ukraine, there was no drugs often that were able to treat people. So if we look here, the prevalence of tuberculosis in Ukraine, this is modern data for 2019, but still a lot of people die. Look here, the mortality, HIV negative TB mortality, 3,200 people, and HIV positive mortality, 1,900 people. This is per year. So, and this is in Europe. This is not far away, just like around the corner, one can say. 1,000 people die of tuberculosis presently. And again, in Ukraine, 34,000 people are sick with tuberculosis every year. We can look at Romania. This is also Europe and even EU country. And you see that in Romania, 13,000 people every year getting sick with tuberculosis. Is anybody dying in Romania of tuberculosis? Yes, quite a lot of people. About 800 people die from tuberculosis in Romania every year. And you see there is a decline. Of course, there is a decline. We're fighting tuberculosis and we're decreasing it. Romania is doing a lot of effort, but apparently not enough because people are still dying and a lot from tuberculosis in Romania. This is Sweden. Are people dying from tuberculosis in Sweden? Yes. In 2019, 25 people died from tuberculosis in Sweden. And around over 500 people were sick with tuberculosis. And if you look at the curve, it's not like declining. It's going up and down. And this top, this is about local challenges. It's true, when the migration wave was the highest in Sweden, tuberculosis also reached to the top levels, but luckily the health system answered with opening more tuberculosis care centers, like in Umeå, they started with a TB center, which is still working, and this is like really good because then we immediately saw a decrease of tuberculosis. So this is the thing with tuberculosis. I will go back to Ukraine and will show you one more map or graph. Since there is no vaccine against tuberculosis, we have to control it all the time. In my country, in Ukraine, in 1990, there was not so much tuberculosis, not like now. But then the country went into collapse. We had like horrible economic situation. And what has happened, it started immediately to grow, reaching like huge and horrible numbers. So now we're spending billions and billions trying to put it down, something that we lost. With tuberculosis, you cannot relax for a minute because as soon as you're forgetting about it, it will not forget about you. Unless we have vaccine, we will have to monitor and treat and find cases and do preventive treatment. Thank you very much.
Thank you so much, Olena. And thank you for also sharing these perspectives from Europe and Sweden. As you say, I think most people that I know and that I've studied with are not aware of these issues, that it's also such a local question. And now we'll leave the presentation to Rashmi, and you will let us know a bit about the perspectives in India.
Yeah, thank you, Hannah. So I will just share my screen now. And yeah, is that good? Okay, yeah. So you can hear me, right?
Yes, perfect.
Yes, okay. So yeah, so as I introduced myself before, I'm Dr. Rashmi Rodriguez, Associate Professor of Community Medicine in Bangalore. I will present a few perspectives from India, a little bit of my work included. So, well, we kind of globally have estimated that there are about 10 million people with TB annually. But we report about only 6 million actually diagnosed people with TB globally. And one of the reasons for the reduced numbers of diagnosis is either because patients do not report with their symptoms in time or are sent from physician to physician without a proper diagnosis, while others are diagnosed but are not reported to the healthcare system. And if we come to India itself, we have about 2.4 million patients that were diagnosed with TB in 2019. India actually contributes about 25% to the global burden of tuberculosis. And we have an estimate that about 1 million patients with TB in India are not really being diagnosed or reported to the healthcare system. We have a very well-developed reporting technology portal, which is called NICSHI, wherein both private as well as public healthcare providers are expected to feed in information regarding patients with TB, just like we do these days with COVID-19. This has, to a large extent, improved the notification or the numbers of TB patients with TB reported from India itself. We did one study in our hospital here at St. John's, and we did realize that that there were issues and gaps with TB notification, especially from the private sector, which was, of course, very well known. You can pick out this article from the BMJ Open and have a look at it. Yes, I have, to a large extent, India kind of has one of the largest national tuberculosis programs. And we roll out anti-tubercular treatment at no cost to most of our patients with TB. While most of the patients actually kind of go to the private sector for diagnosis, for general illnesses, for tuberculosis, most of the diagnosis is through the healthcare system, and the treatment is also at no cost through the public healthcare system. And I think this is the reason why the public healthcare system, specifically with TB, is so very well adapted to identify and manage patients with TB in India. However, we are constantly trying to get the private sector involved with the management of tuberculosis in India. One of the important gaps and issues or challenges that I would say that we have with the management of TB, both in the public and the private sector, is an adherence to treatment, that is anti-tubercular treatment. So we have, as we know, or as we have heard perhaps before, adherence to treatment itself is rather a complex phenomenon, and it requires, or it is contributed to both by individual as well as health system factors. And one of the things that we came up with, I mean, the international community as such came up with, I would say, was directly observed treatment for tuberculosis. That is, a patient that is constant, or a patient is observed while he or she takes their medications by a supervisor or a healthcare provider. This was done, I think, when one of the early studies in the 1970s and 80s in India actually found that when people visited patients' houses, they retrieved a large amount of medications that were not taken by patients. And then it became a norm, or rather it was a strategy that was employed globally for patients to be observed while they were swallowing their medications. Now with technology, this has changed to a large extent by making monitoring digital. So I was initially involved with digital monitoring of HIV treatment, which we tried at our own hospital here in Bangalore, with limited success, I should say, while there were several studies from Africa that did show a good effectiveness of digital support for treatment adherence. But then I thought of adapting the technology for tuberculosis, especially as tuberculosis treatment required constant monitoring. And we did have collaborations, especially with the US, and we came up with 2 ideas. One idea was 99 Dot, which Microsoft Research and myself developed in collaboration. Of course, I have moved out of 99 Dot at the moment and kind of have started work with Video DOT, which was developed with support from Johns Hopkins in the US. While we did want to use the technology from the US, we realized that many patients in India may not have mobile phones that would support their application, because of which we had to develop our own video observed treatment application, which is called VCure and is downloadable from the Google Play Store. However, this has to be activated by the physician if the patient needs to be monitored via this application. This is how it works. So a patient records themselves while they are swallowing medications. And on the back end of the application, we observe the patient taking the medication and we provide feedback. So we have, of course, at times observed that patients do even cheat this kind of a system. But as we constantly even keep in touch with the patient, like we kind of give them a phone call if we have observed some inconsistency of patient, or patients have not sent in their videos, that way we kind of provide additional support. This application or this concept is currently being trialed in a randomized control trial here in our setting. Of course, the next challenge that came up last year was COVID and tuberculosis. And I would say there were a lot of reports globally that said we will probably have a setback in achieving the global targets for TB because of COVID. And one of the major issues that we had was with the diagnosis of TB itself, which was reported from several frontiers, like largely newspaper agencies, as well as the World Health Organization and Stop TB came up with reports saying it is likely that the diagnosis is affected, and this will probably affect, my slides are not moving. Okay, yeah, right. So this would probably cause a setback in achieving the global TB goals. But there were also other concepts which said that, you know, isolation and masks that were used for COVID might also prevent the spread of tuberculosis. So we decided actually to do a small study wherein we did find the fact that there were issues with the diagnosis of TB, which kind of dropped significantly during lockdown and after lockdown. It has now picked up with the resumption of normal care for all disease. So we will see what happens. We currently in India seem to be having a second wave of TB that has just about, sorry, not of TB, but of COVID that has just begun, and we hope it will not be as bad. We also used a qualitative approach for COVID and TB, wherein we did find that patients did have issues with diagnosis. There were issues, especially because the symptoms of COVID and TB were quite similar, and it delayed the diagnosis of TB because they kind of required a COVID test before they would be diagnosed with TB. So if we were to kind of so I have worked with TB to a large extent now, maybe for the past 5 years. I have received a lot of funding from several agencies, etc. And one of the ways I thought that was good to give back to the community that we work with was to do something for the community. And we developed this concept, which was kind of being used by one of my funding agencies, that is DBT Wellcome Trust India Alliance, for antimicrobial resistance, wherein they used grassroots comics for health education. So for tuberculosis, this was a group of healthcare providers, both TB healthcare workers that actually monitor and provide treatment to patients with TB, as well as physicians and doctors, that came together to develop comics for TB. They drew comics, and we had a person, Mr. Sharat Sharma from World Comics India, who kind of introduced people to the initiative. People needn't have known to draw at the beginning of this workshop, but at the end of this workshop came up with some excellent comics. Of course, we did have artists also, and this is one of their stories that came out of the workshop, which we will actually be using for health education in TB in Karnataka. That is the state in India that I work. So with this, I think if we all get together, I'm sure we can end TB and actually meet the global TB goals, NTB goals. And let's all move towards that. Thank you so much for inviting me. It's been a pleasure to be on this panel.
Thank you very much, Rashmi. Very interesting, new and innovative ways of treating TB and working on the community level. We have received not that many questions, but 2 of them. So I think we can take those now before we take this little quiz. The first question I can leave open to anyone who wants to answer it, is about TB in children, which wasn't mentioned that much. What is particular about TB in children, and are children with TB infection contagious, such as comparably to adults? Anyone from the panel wants to?
Yeah, I can start. I think that's a very interesting topic, because children are always stated as being more, children up to the age of 5 or 7 or so are stated to be especially susceptible to develop active TB. So to me, that's always been a discrepancy, because when you look at TB registers throughout the world, wherever we may be, the proportion of children is being treated for active TB is usually very low. And even in low-income countries, there is the inverse population pyramid. So most of the population are actually children. So I always find that strange to know. And I think it could be an issue of underdiagnosis, because active TB is difficult to diagnose in children. So I'm sometimes thinking that a lot of children, maybe they die with TB without ever being recognized that TB is the reason for their death. So it's highly relevant. Maybe Rashmi or Androlena want to give some comments as well.
Okay, yeah, maybe
I want to comment. I can do after you.
Okay, so so yes, we do see a lot of children with TB, especially in India, yes. Infectivity wise, it depends whether it's pulmonary TB or no. But I think largely children are as susceptible to TB as anybody else. And we have systems in place to address children with TB by itself. Of course, we vaccinate all children at birth with BCG, and we are aware that it largely prevents the childhood forms of TB, and that is why it is given, and not really the adult forms of TB. Yeah, so to a large extent, we do hope that the vaccination takes care of either the severity or the infection itself to some extent. Yeah, so that's what I would like to say.
I would like to add also to what Rashmi said, that it's very important to keep vaccinating with BCG, because when in these high incidence settings, there are shortages of BCG and children are not being vaccinated, statistically one can see increase of the childhood tuberculosis. Then another question is the diagnostic in children, which has its own specific peculiarities. It's not so easy to take samples from children for culture, for example, because they don't produce as much sputum, don't cough as adults. And in this sense, there's been made some advance in the diagnostic, because they started to do PCR from stools of children. And that can improve the diagnostic, which indicates that more research should be done to increase coverage of good diagnostic in different groups of people, because say this new approach with stools can reach to those children who are not being diagnosed by other methods. And more work should be done. WHO noticed, I think 2 years ago, that 100,000 children has been missed their diagnostic, and it's not excluded that some die without being even diagnosed. It's an important question.
Yep.
Thank you for those answers. We have one more question now. It's a question for Dr. Rodriguez. What would you say is the main reason for patients to cheat with taking the medications for TB? Are the medications sold?
No, by cheating, I mean they do not really take the medications. So what are the reasons? I think the reasons are not really, at least in India, I wouldn't think the medications are sold. The reasons why they wouldn't really take the medications is largely due to the side effects of the medications. So they're not comfortable with swallowing, like they, sometimes have to take 3 or 4 pills in a day, and they are not comfortable with that. They are also not aware, perhaps, that they need to take medications for 6 months, and that they have to do it daily, because in a country like India, where a physician perhaps maybe in a span of 2 hours or 3 hours sees about 20 or even 30 patients, including patients with TB in a day, they may not be able to spend as much time with the patient. So not everything may be communicated to the patient, and the patient may think that if he drops 1 pill here and there, it may kind of be okay for him, and eventually he would get over it. So there are awareness issues as well as side effects of medications, etc., that might prevent patients from actually taking medications. And of late, we've also heard this concept of why should we monitor patients? Why is monitoring or visually seeing that a patient is taking their medication absolutely important? Because there are so many other diseases for which patients do take medications and complete their treatment. So why can't we trust a patient with TB? And there may be patients also who perceive it in that way as to why should I be monitored when I can actually, take my treatment on my own? So maybe for the purpose of the video recording, they might do certain things, not really kind of show that they're taking medications. They might be taking medications otherwise regularly. So it's not just one aspect, it's several things that come together, and it may be different things in different patients.
Thank you. Per, did you want to add something to that?
Yeah, I think that's an interesting topic. So I just wanted to add about adherence, as Rashmi said, it's a complex phenomenon. And I think in general, the health system and we as physicians tend to put the blame on the patients. Why don't they take the medicines? Are they cheating, or they are forgetful and all that? I think we should also consider that this problem with the long treatment, we have to, as physicians, we have to make sure to provide the treatment in a way that the patient can comply. For example, we are treating patients sometimes with psychiatric diseases, those that are homeless, those that have drug abuse. So we have to modify the treatment for their purpose. That concerns not just TB medicine, but also antiretrovirals, as you mentioned. So I think that's a very important aspect to consider.
Okay, we did receive some new questions now, but we thought we might just take a quick break from talking and do this little quiz that we've arranged for everyone, just to get a pause, and then we'll continue with the discussion. So the quiz is a Menti quiz. I'm not sure if everyone is familiar with that, but I'll take up it here. So if you want to participate, whether you're an attendee or a panelist, you can go to this menti.com and enter this code. This is also a good time to stretch your legs a bit, maybe grab something to drink. And I'll give everyone a minute to join in for the quiz.
Wait. Well, the code 25. This is the code.
The code is up 25829455. It's at the top of the screen, I think. Okay. So we have a few competitors here, I see. Okay, some more joining in. Okay. Has everyone, if I'm asking the panel, has everyone who wanted to join joined?
No, I didn't manage to find it.
Okay, well, I'll give you a moment, Penalina.
2582.
Okay, well.
No, I'm afraid I'm not.
Okay, well, we'll start, I guess.
You start.
And we'll see how this goes. So the questions are quite quick, and it's multiple choice questions. And I think you get a higher score if you answer quickly, but maybe you should take a little time to think as well for some of the questions. So it starts now. A history question. Okay, so the correct answer is actually about 1 million people every year died in Europe at the early 20th century. So that says a lot about what Per and Bolena was talking about, that we've come a long way in Europe, but we still have issues left. Okay, next question. This might be a tricky question. So, as Elena was mentioning, the Central Asia and Eastern Europe is quite has a large burden percentually of multi-drug resistant TB, but since India is the country with the most TB cases in the world and also has issues with this, it's actually in total burden most multi-drug resistant cases.
By numbers.
By numbers, yeah. Okay, next question. This is not working as, okay. Okay, so all of the answers would have been correct, but I guess the most correct answer is to say that all of these factors are important risk factors, as Per was mentioning in his presentation. We'll see if you can remember the numbers Olena presented before. It was quite hard, but the majority got it right, I guess, with 95% reduction of deaths and 90% reduction of cases for 2035. And finally, we have a question about COVID, which we also want to talk more about in the panel discussion. Okay. Yeah, so I mean, definitely the awareness of TB has been reduced, but this model was based on that, the reduced detection rate, which Rashmi was also mentioning in her presentation. But there are definitely a lot of aspects about how COVID has affected the TB response. Okay. So let's see if we can see who won this quiz. Yes, Emma, congratulations.
Well, I guess I was also a little bit cheating because I was in and also with the creation of the questions. Okay, so maybe it was unfair. I don't want to be the winner. I'm sorry.
I guess we'll say that Anna was the winner then.
Yes.
Because that's true. That's not really fair. Well, thank you all for playing. Good job. We'll continue with the panel discussion now. Okay, Hannah, you'll take over now, right?
Yes. I think we got another question here in the chat, so I'll start with that. And it is, how does stigmatization and segregation to TB patients in India influence uptake of available care?
Yeah, okay, so we have some experience with working with that. Uptake of TB care, yes, there is stigma related to tuberculosis, but in a way, it's not as much as that associated with HIV infection. But yeah, the fact that patients sometimes have to come and collect their medications or be observed by someone while they're taking medications does cause a lot of stigma. It has affected, especially for girls and women, affected marital prospects. And people are always wary of kind of telling others that they have been infected or have been diagnosed with TB. So yes, it also affects prospects at work sometimes. People might lose their work. So that itself is a challenge, because when that happens, then they cannot access healthcare, and they do not have finances to travel for diagnosis, for treatment, and for continuing treatment, and to support their families. Also, family support itself sometimes is a problem to kind of be adherent to medication, or to continue the medication for 6 months. Families that have been diagnosed with TB have separated sometimes, have split, because we have large families in India, and they are joint families where several brothers stay together with their wives and children in the same household. So when one person in the family is diagnosed with TB, a lot of times they split up, and then that again causes issues with treatment and accessing care and things like that. Of course, if people in a community are aware that there is somebody in a family with TB, then they kind of maybe to some extent not be treated very well. However, we strongly believe that these days, the fact that treatment is available and patients are aware of that, and the communication regarding hygiene and awareness regarding the fact that treatment can sterilize sputum within maybe a period of 72 hours, when you kind of communicate to the patient that, and the family, that patients may not be infected for too long after they have started treatment. People do come around, and it's kind of found to be awareness, especially awareness generation, has found to be kind of a means by which we mitigate stigma in the community and in families, and enable patients to seek care and complete their treatment.
Thank you for that answer. Would you like to add anything on the issue of stigma, Per or Olena?
Yeah, I can add on stigma. Of course, it's a huge issue, because it's very embarrassing. In Eastern Europe, it's very embarrassing to be sick with tuberculosis. For some reason, it's connected to, it feels like people should be blamed themselves for having tuberculosis. It's not like any other disease. And that, of course, should be addressed. Now, I think these masks that people started to wear under COVID, I think it took us a long way forward, because previously the people with tuberculosis, they didn't even dare to wear masks outside, because it was one of the signs of stigma. And now, just like this, we managed to overcome it, because a lot of people started to wear masks. So a thing like that, for example. But of course, a lot should be done, because people are shy to go to the doctor to tell about their situation. That can delay the diagnostic. And I was thinking, Rashmi, I know one organization in Pakistan. And then I was so much surprised, because they were like using the school children, or engaging school children to go from house to house to ask people for symptoms. And this is how they were finding new cases with the tuberculosis. And they're very efficient. These are schoolgirls going massively into households. But I was thinking that in Ukraine, this situation wouldn't be possible, because if parents in the school would hear that their children will go from house to house and ask who's here having symptoms of tuberculosis, they would never allow. So I think in some countries, the situation is better, because we know you cannot get infected by tuberculosis very quickly. It's not like COVID. You need to be in the close contact. That's why tuberculosis is very much in families or in the places where people interact a lot, because it's not so easy to get infected. But there is a lot of ideas and prejudice about that. So a lot of work should be done. I think the pedagogical investments and training of people and information should be distributed as much as possible.
Thank you for that answer, Olena, and also highlighting that different models might be best in different countries, and that we have different situations. I'll take another question. And I see that there are a lot of questions coming in, so keep them coming. Next question is, the COVID-19 pandemic has affected the global response to TB, as well as many other diseases. Can we catch up the lost progress? Will we learn anything from it? And did anything positive come from it? Perhaps, Per, would you like to start answering?
Can give it a try. It's quite a big question and quite uncertain. And I mean, we have to be optimistic, obviously. I think what COVID has taught us in a way, like you exemplified with these figures of the Olena on the spending for COVID, that we can really gather a lot of resources in the world where we are faced with health problems. That was also the case, but on a, I think, smaller scale, but a bit more protected with the global response to HIV and the scale up of antiretroviral therapy that we have seen since the beginning of the millennium. So I think we have learned a lot on how to act with that. There are also some mistakes that have been done in COVID, I think, like this closing of borders and separation of different countries and communities and so on. But research-wise, especially with regard to vaccine, I think there are new, I mean, we should be a bit cautious comparing COVID and TB with regard to vaccine, because I think really vaccines against TB is much more of a challenge than COVID vaccines. So yeah, whether we will catch up or not, I hope so, but I think we have to live with those consequences for a long time, and some of which will remain hidden. We have estimates of how many people have died of TB because of not being diagnosed, but we don't know for sure. So these people bring their secrets with them in their grave. Yeah.
Thank you for that answer. Rashmi, would you like to add something to that?
Well, okay, so yeah, so we have been kind of monitoring the data that has been coming in regarding TB during the COVID pandemic. And we have, of course, I showed you that there was a decline in the number of patients diagnosed. But however, I think with time, we've also kind of have a slight forecast of a reduced incidence, but that might also be because there was to begin with, we had a lower trend in the year itself. So we don't really know where it will go. And one of the factors that might be contributing to this is the fact that many people are actually working from home, and the spread of TB might be within the family rather than between at workplaces and things like that. And people are also kind of masking up, and hygiene, which is very important in TB, is catching up because of COVID. So especially in countries like ours. So we don't really know. Of course, on one side, we might think that, you know, TB may be adversely affected, while on the other, the incidence rates may currently, I mean, of course, we can only confirm this when we have some more data, I would say, that the trends in incidence may be a little lower over time. However, the deaths we have observed are, of course, you know, the proportions of deaths kind of seem to be a little higher because of the, I mean, through the pandemic. And that's kind of the forecast that appears to be coming through from actual data from the field.
Did you have anything more to say?
Yeah, when Rashmi started talking, I was thinking one other thing that I was going to mention before about one thing that we could learn from COVID and that we know already from TB is case finding around contagious cases of pulmonary TB. And I think that's working quite poorly in many settings where I've been working, where we have people who have smear positive pulmonary TB. That's the most contagious kind. And I mean, in Sweden, we do an extensive tracing of contacts, but in many places where I've worked, in other countries, that's really neglected. And I think if we could work more on that, like we are doing now quite actively in many places with COVID, and I think that might be one way forward, not just to find cases, but that will also lead to reduced incidents actually, because then we break the transmission, we can get them under treatment. So yeah, that's one thing.
Yeah, if I could just add a point, yeah. So what we've kind of done, actually what the system has done in India is that since the TB program realized that the diagnosis was kind of being affected, they tried to combine TB and COVID, the TB and COVID algorithms to enhance diagnosis of TB. So that's kind of what came in place. And it's kind of helped us largely, and because a lot of diagnosis initially was also through smear microscopy. With the WHO recommendation and the implementation of that, everything moved towards GeneXpert, the handling of sputum in a way for the purpose of microscopy, and the generation of aerosols was kind of minimized. So it kind of, yes, so COVID and TB and amalgamation of the two algorithms would probably be beneficial in the long run, but it would, I guess, depend, be based on the health system in every country or part of the world.
Okay. Thank you for those answers. We have some questions left from the audience, so to try and catch up with those before the time runs out, I hope you can answer them a bit briefly. The first question is about vaccines. So maybe Olena could comment on that. And that's, well, firstly, will we get a better vaccine for TB? And also the audience member was asking if we do get a better vaccine for TB, will we have an issue such as with COVID, that we don't distribute the vaccine to the countries with the biggest need, do you think?
Well, I'm a big expert in vaccines, but I think here the situation would be different than in COVID, because what happened with COVID vaccines is like rich countries develop vaccines basically and use it at the first point without sharing it to the countries that have no possibility to develop or to buy, right? This is what we think is unfair, because the pandemic is global. But with TB, we still have those leading countries, and say that would be, I think, natural that they distributed there. I mean, Sweden wouldn't be first in the fight for tuberculosis vaccines, and if it would be, it wouldn't be so many that would be needed. I think it would be logical to give it to the countries with the highest priority. I think the main problem is that there's too little investments in vaccine development. And I agree with Per that probably there are some challenges with developing tuberculosis vaccines, but honestly, I can't imagine that that's so difficult that it wouldn't be possible to develop. I think it was not enough resources, not enough priority, just because of these poor countries suffering from it. And that's never been on the agenda. If, for example, half of the European Union all of a sudden got tuberculosis, the vaccine would appear in 2 years. This is what I think. I mean, this is private opinion. I'm not expert in vaccines, but this is how I see it.
Yeah. Okay. Another question from the audience? Or
Rashmi probably wants to say something about vaccines.
I just want to say something about vaccines, because I'm working with a vaccine trial in India at the moment.
Oh, yeah.
We're trialing two vaccines for TB, and we're doing it in household contacts, because I think the transmission is largely found in, it's one of the populations that's very easily accessible, and we can follow up over time. That is, if you find a patient with TB, their contacts, we could kind of trace their history and other things. So so we are kind of in the process. Of course, I do not know the results, but we are kind of midway. We've just finished recruitment. We had 18 centers in India, and we're just one of those centers. So it is quite hopeful in a way, I should say. And yeah, let's see what comes out of it. So yeah, vaccines are still being trialed, I think. And,
yeah. That sounds helpful, at least. We'll hope those trials do well. So there was a question from Anna in the audience who was wondering, a question for medical students. What can young medical students do to contribute to reaching the goals of fighting TB in the world? Anyone wants to comment on that?
Yeah, I can comment if it's okay. I think one can do a lot because Sweden has very good education for the medical students, and what is needed is the human resources of engaged people who are really interested in the topic. As Rashmi mentioned that in countries with high incidence, sometimes a physician is not even able to look properly at the people with the those issues to diagnose tuberculosis. And I mean, one can join MSF, one can join organizations like our network, TBNet, try to raise more data, contribute with research. And I think MSF is doing incredible work. They have clinical trials on the tuberculosis, different regimens of the new drugs. And now recently they closed the one trial early because they showed that it has a superior effect on the treatment, a new regimen. So these kind of things, they're very needed, and engaged people, they will be always helpful and will contribute to advances, I'm sure.
Thank you. Would you like to add something short to that? How to get engaged as a young colleague or a medical student? Any other suggestions?
Yeah, I can
just
our organization. Yeah, Per, please.
No, it's a very broad question, so I just wanted to commend you for arranging this webinar. I mean, that's actually one start that you can do. When you ask yourself as a medical student or as an individual physician or researcher, what can I do? It's easy that you feel hopeless because I can't do anything, and we can't do anything, of course, to fight all these challenges and to make it right. But just by doing small things, we can, at the end, we can contribute to do a lot. That's what I would say. I think it's a very good initiative that you're taking, and thanks for inviting me to join this.
Thank you for joining us.
Yeah, thank you so much. And we're running out of time, and if anyone here in the webinar needs to leave us, you're free to do so, and we will record this webinar also so that you can find it on the Swedish Society of Medicine's YouTube channel later. But we would like to round up with the last question, and if you could try to answer that with just like 1 or 2 sentences, each of you panelists. And it is, what are the most important next steps to combat TB in your opinion? So you can answer either globally or in your local setting from your research perspective. I know it's difficult to do it brief, but as brief as possible. Anyone would like to start? Perhaps Olena, what would you say are the most important next steps?
I've been talking about vaccines all the time. Myself, I'm not working with it. I try to address diagnostic of in different ways, but I think vaccine is the most important. If we have vaccine, then it will curb the epidemics dramatically.
Thank you. Rashmi, what will you say?
Well, I think in populations like ours, awareness, both in which I say in the patients as well as the healthcare providers, because for the healthcare, for the patients, it's the diagnosis that's important. While from the healthcare provider's perspective, they need to give the patient the right regimen. A lot of times, you treat patients with just one drug or two drugs, and it's not the right regimen. There's resistance that develops, and that just causes a setback. So both, it needs to be, a combined action of both awareness in both patients as well as healthcare providers.
Thank you for that.
Very important. Yeah. Per, do you have any?
Well, it's a difficult question, and I was actually thinking, if you were talking about the next steps, like what lies next ahead of us, I'll give a little bit boring answer maybe, but I think we should not. Of course, the new technologies are very promising and the research is important, but we can't just wait to say that when we get a new vaccine or we get a better technology or better drugs. I think what we should do next is to learn how to use the tools that we have more efficiently, actually. That's because we actually know quite a lot about tuberculosis. We don't have an effective, we don't have a perfect vaccine, but as you mentioned, it's very good in children, and we don't have perfect diagnostics, but we have a diagnostics that we can use, and we have treatments also that we can use. So we should learn how to use them better, and because just finding new antibiotics, it won't solve the treatment situation. Finding some new diagnostic won't find that. So yeah, it's a complex issue. That's what I would.
But I think that's, you're right, it's very complex, but it's also hopeful to think that we do have a lot of tools already at our disposal, and that we just need to prioritize better. I think has been a message in this webinar as well, that we haven't focused enough on TB in the last decades, perhaps. Yes, Hannah, anything else we should say before we wrap up this webinar?
No, just thank all of our excellent panelists, our guest speakers, and also all of you attendees here today. And also, yeah, thank you, all of you have been engaged in arranging this webinar.
Yeah, thank you very much to all our panelists for taking your time to prepare and to answer all these questions. It's been very interesting. And I think both the people watching now and later will definitely have a lot to learn. I have for sure, so. Oh, and you can see some thank yous coming in from the chat from attendees as well. And if anyone is interested in these questions, global health issues, etc., and wants to know more about the organization that we come from, you can contact me or Hannah. You can write our emails down below. If you want to become a member of the organization or just interested. And I guess, is it okay for us to leave your emails to the attendees, panelists? So if they have any questions for you, they can write later. Okay, then we'll do that. Sorry for going a bit over time, but thank you all for this, and happy Easter if you're celebrating that, and take good care. I guess we'll end here.
Thanks a lot for organizing. Great initiative.
Yeah, thank you so much. It's been a pleasure.
Yeah, thank you.
Okay. Well, bye everyone.
Bye-bye.
Have a nice evening.
Okay, bye. Bye.
Thanks so much.
Bye-bye. Thank you very much. Very interesting.